Okay, so I am again delighted to welcome everyone to this webinar on advancing comprehensive suicide prevention and overview. We're delighted to welcome an international audience from both the United States and our Canadian neighbors to the north. And the reason that we have an international audience is that this webinar is being co-sponsored by the Substance Abuse and Mental Health Services Administration in the United States, the Public Health Agency of Canada, and the Mental Health Commission of Canada. My name is Eileen Zeller. I'm lead public health advisor in the suicide prevention branch at SAMHSA, and I'm very pleased to introduce today's speakers. The first speaker will be Richard McKeon. He is branch chief of the suicide prevention branch at SAMHSA. He's also my boss. Following Dr. McKeon's talk, we're going to have Stephanie Priest speak. She is Director of Population Health Promotion and Innovation Division in the Public Health Agency of Canada. And following her will be Ed Mantler. And Ed is Vice President of Programs and Priorities in the Mental Health Commission of Canada. Following Stephanie and Ed's talk, we're going to have 5 minutes of questions. And I will tell you that as Stephanie and Ed are speaking, if you take a look at your screen in the left-hand column, there's a Q&A box. If you have questions that come to mind as they're speaking, go ahead and type them in. And you will only you will be able to see your questions, but I will be repeating them, as many as we can get to, for the speakers after they've finished. So after Stephanie and Ed, I'm delighted to introduce Dr. Jerry Reed. Jerry is Vice President of the Education Development Center. He is Director of the Center for the Study and Prevention of Injury, Violence, and Suicide, Director of the Suicide Prevention Resource Center, and I want to thank the SPRC for hosting this webinar on their platform. And Jerry is also an Executive Committee member of the National Action Alliance for Suicide Prevention. Again, after Dr. Reed speaks, we're going to have some brief questions for him. So again, type your questions in the upper left-hand column, and we'll make sure that we get to as many as we can. And then we will have some joint questions for all of the speakers. We'll close at 3:25, and we'll end the webinar at 3:30. And now I am delighted to introduce again Dr. Richard McKeon to start off our webinar. Richard.
Thank you very much, Eileen. I'm really pleased to be able to speak with you today and to participate in this webinar on comprehensive community-based suicide prevention. I'm particularly pleased to be able to do this in coordination with my colleagues from Canada, Stephanie Priest and Ed Mantler. So I'm going to give you an overview of the webinar series that we will be doing and some of the key issues that will help frame what we're hoping to accomplish during the series of 6 webinars. So let me start with underscoring the extent to which suicide is a global problem. The World Health Organization recently released about a year or two ago their first ever World Suicide Report. In that report, they estimate that approximately 800,000 people die by suicide each year around the globe. And they called in their report for nations to set ambitious goals to reduce suicide and to implement comprehensive national strategies or national action plans in order to reduce death by suicide within the nations of the world. The WHO is also working currently on a document called Preventing Suicide, a Community Engagement Toolkit. It's not available yet, but we are hoping that perhaps later this year it will be available as a toolkit or guide to assist communities in doing comprehensive community suicide prevention initiatives. So one of the things that I would like to point out, and one of the goals of this webinar series, will be to familiarize you with some of the initiatives that are aiming towards trying to have a comprehensive, evidence-based community suicide prevention effort. And there's work going on in different places around the globe. You know, we will often say, and we say in the United States National Strategy, that everyone has a role in suicide prevention. But we know that we need to do more than just say that. We need to help people understand more what their role is and what are the roles of their organizations that they may be participating in. So you'll be hearing shortly from Stephanie and Ed about the work being done under the auspices of the International Initiative for Mental Health Leadership, and you'll be hearing from Jerry Reed about the work that is being sponsored through the National Action Alliance for Suicide Prevention. You'll hear about both of those initiatives today. There are other initiatives that you'll be hearing about as we go through the 6-part webinar. So I'm not going to go into detail about them here, but just to perhaps whet your appetite a little bit, if you're not familiar with them, there's been an effort that's gone on in Europe over the last number of years, the European Alliance Against Depression, sometimes referred to as the 4-level intervention. So rather than trying a single suicide prevention intervention and hoping for the best, the idea is to do multiple interventions at the same time in order to have a greater effect. Now, one of the things that's particularly noteworthy about the work in Europe is that they have evidence of effectiveness in reducing suicide. Started in Nuremberg, has been repeated in a number of countries, and has shown more success in some countries than others, but certainly enough evidence that is something we want to give close attention to, and we will be sharing that with you later on in the webinar series. There's also a very ambitious and very encouraging initiative really being launched right now in New South Wales, Australia, which is a comprehensive approach that has been written up in the literature to suicide prevention with a rigorous evaluation that will be going along with it. So we're all very much looking forward to see what the Australians are able to learn from their efforts. In the United States, we have had for the last 10 years a major youth suicide prevention effort. It was authorized under a piece of legislation called the Garrett Lee Smith Memorial Act. And we have provided grants to states, tribes, and college campuses. At this point, every state in the United States at one time or another during the last 10 years have received one of these grants. And one thing we'll tell you more about is that we have evidence of effectiveness in reducing suicide deaths and non-fatal attempts. However, only for the first year. The effect faded by the second year. So we will let you know more when we get to that part of our webinar series about why we think we had an impact and why we think the effect faded. Now, in the United States, we did release in 2012 a revised national strategy for suicide prevention that reflects exactly this kind of comprehensive approach to suicide prevention. And it remains the guiding force behind our efforts. In fact, just yesterday, Dr. Reed and myself and a number of other people were very fortunate to have been invited to the White House on a suicide prevention for a suicide prevention meeting. And part of that was looking at the goals 8 and 9 of the U.S. National Strategy, which focus on suicide prevention within healthcare. But there are numerous parts of the strategy that focus on community-based suicide prevention. This references what I've mentioned before, that we have done an evaluation study of the impact on youth suicidal behavior of our efforts to provide comprehensive youth-based suicide prevention. Now, one of the things that I'd like to mention to you is that we've tried to take a look here in the United States at whether our national strategy was actually being implemented or not. Because it's great to have a strategy, but if it sits on a bookshelf and it's not used, then it's not going to do anyone any good. And there were several key recommendations that came out of this implementation assessment group. One was the need for a consensus around the core components of a comprehensive, research-informed community approach. Another was for the greater specification of roles and associated activities than we provided to date. And the third was the need for a blueprint or a toolkit, something to give people more guidance about what they can do within their communities. So let me say that comprehensive suicide prevention is important, and this is going to be an arbitrary distinction. But one can conceptualize a comprehensive approach to suicide prevention as requiring two strong elements: a strong multi-pronged community effort and a strong multi-pronged healthcare effort. Now, obviously, the healthcare is part of the community in very important ways, but at least conceptually that we can make this kind of distinction, and we think there needs to be more focused on what those components of a community effort should be. We also think that there needs to be attention to transitions across a range of different kinds of settings, not only within healthcare, but in and out of justice systems, or going into or out of college campuses. In the United States, we also focus a lot on the transition between leaving the military and being covered by the U.S. Veterans Administration. And the idea that our efforts should be data-driven, we believe in the United States coordinated by a public-private partnership, and it needs to be sustained by a strong infrastructure. So when we talk about community-based suicide prevention, we want to think comprehensively about some of the settings that need to be engaged in it. Schools, and as well as colleges, including elementary schools. Think about things like the good behavior game, which has shown an impact among first and second graders. Certainly there's a lot of work that's going on that's focused on high schools, and colleges can also be an important setting. Justice settings are very important. They're both for adults and for youth. One major study in the U.S. found that 63% of the youth who died by suicide in our state of Utah had previous juvenile justice exposure. The workplace. For adults, the workplace is where many, not all of course, but many people can be found, and so workplaces need to be engaged, as do faith communities. Like faith communities, suicide prevention people need to have a strong emphasis on hope, and we are working with the Action Alliance and with others to engage faith communities in suicide prevention. Foster care as a system for youth, critically important, and then for adults, the veterans or military in the U.S., our National Guard, all of vital importance for our suicide prevention efforts. So, as I mentioned before, this is a 6-part webinar series. Today will be the overview and introduction, and you'll hear about the work from the International Initiative for Mental Health Leadership. You'll hear about the work of the Action Alliance. The second webinar will focus on models for community suicide prevention. The third on sustaining effective comprehensive community suicide prevention efforts. The fourth will focus on community suicide prevention among indigenous populations. The fifth will let you know about some emerging comprehensive community suicide prevention efforts. And finally, the sixth will be on bringing the pieces together, developing a blueprint for community suicide prevention effort. So as we continue this important work, we also want to know what you feel you need to most effectively perform this life-saving work. So we're very much interested in the question and answer periods that you let us know, not only when asking specific questions about some of the material we might present, but also if you can communicate to us what you feel you most need, that would be very important information for us to have. So I'm very much looking forward to today and to the entire webinar series. That's my contact information, and any of you are welcome to get in contact with me by phone or by email if there are further questions you want to ask that come to you that you're not able to put through the question and answer chat functions today. And with that, we'll move on to our next presenters. And Eileen, were you going to do an introduction here?
I was. And first I want to thank you, Richard, for a really informative presentation and a terrific introduction. I also want to remind participants that if you have questions for Richard McKeon or any of the presenters as we go through the webinar, to look on your screen, the left-hand column, it'll say Q&A, and you can type in your questions there. And after Stephanie and Ed speak, and again after Jerry speaks, we will have our Q&A session. So please, we really need your questions, both to inform us and to provide whatever information we can. And now I am delighted to reintroduce Stephanie Priest, Director of Population Health Promotion and Innovation Division in the Public Health Agency of Canada, and Ed Mantler, Vice President of Programs and Priorities for the Mental Health Commission of Canada. Stephanie? And before Stephanie speaks, she may be on mute, but before she speaks, I do want to remind everybody that yes, the webinar is going to be archived, and yes, the slides will be available. In about a week, you will get an email letting you know where you can access them. And now I will give the stage over to Stephanie Priest.
Thank you. Thank you so much. Welcome, everybody. I'm very excited to be participating in our webinar series. It's been a lot of work putting together and really a team effort. Thank you so much to our American neighbors for setting up the platform and getting us going on this. I think Richard provided an excellent introduction to the series and an excellent overview of suicide prevention interventions and efforts internationally. Today, Ed Mantler and I are going to provide an overview of the meeting that was held last September in Vancouver at the International Initiative for Mental Health Leadership Conference about community action for suicide prevention. So I'm going to kick things off, and then I'm going to turn it over to Ed later on in the presentation, so please bear with me. So to set some context, and coming back to some of the remarks from Richard in his presentation about suicide being a global problem, it is definitely resonates here in Canada as well. It's a challenge that we are facing. Suicide is a significant cause of premature death here in Canada, impacting people of all ages and backgrounds. Every day, an average of more than 10 Canadians die by suicide, and that's approximately 4,000 Canadians every year. It's the second leading cause of death among youth and young adults, and it's the ninth leading cause of death among Canadians overall. So what kind of interventions are working, and why are they working, and what context do they work? What is the evidence telling us? Can we muster the evidence around some of these questions and really use that evidence or bring that evidence into the practice, into communities? These are some of the questions that were framing our discussions and our planning last year for our meeting at the IIMHL. So I'm going to step back for 2 seconds and talk a little bit about what is the International Initiative for Mental Health Leadership, or the IIMHL, IML, for those of you on the line that may not be familiar with the collaboration. It's a network of government and non-government mental health leaders across 8 countries. So that's Australia, England, Canada, New Zealand, Ireland, Scotland, United States, and Sweden. The network is dedicated to knowledge exchange and exchanging experience and ideas amongst leaders to improve mental health and mental health care. The philosophy is that once you connect mental health leaders and they're linked together and they're starting to collaborate together, we can create long-term sustainable partnerships. We're often dealing with all of the same issues, and quite simply, we feel that we can accomplish more together. And the benefits of such a collaboration would cascade down, and do cascade down and up and around to staff, to governments, to our communities, and to consumers. The IIMHL does this through various activities, and the main focused one is what we call a leadership exchange that happens every 16 months or so across the different IIMHL countries. So last year, the exchange was held in North America in Vancouver. It was co-hosted by Canada in partnership with our American colleagues. And it's a week-long conference, if you will. The beginning of the conference has leaders participate in what we call matches. And the matches bring together people from to talk about different topics and exchange best practices and emerging issues. And then all of the leaders come together at the end into a combined meeting. Last year in Vancouver, we had 2 suicide prevention and suicide matches. The one that we're talking about here on community action for suicide prevention, and another match on zero suicide, which was a follow-on match to other meetings that had happened previously in IIMHL. Just to stop here and make a comment on this in the IIMHL community and suicide, we're really starting to see an evolving, emerging, I would say past emerging issue of suicide coming to the forefront of our exchanges, where it started a number of years ago with a match in Oxford, England, that became a match not necessarily about zero suicide, but really rallied around that, and we'll be hearing from Dr. Reed later in the webinar today a little bit more about that. Then followed on to 2 matches in Vancouver last year, and many more coming up, I think, as we move forward to the next exchange, which will be happening in Australia this February coming. The suicide matches tend to be overprescribed. There's a huge interest. And it's one of the reasons why we've split up these meetings into smaller meetings and topics, but also why it's so important for us to bring some of these topics back together so that we're not working in a silo. And what happens in a hospital setting or a healthcare setting connects with what's going on in a community setting. And that we can expand some of the dialogue that we're having at IIMHL more broadly, so that we're touching into all kinds of different best practices and evidence-based more effectively across the world or globally. A little bit about the Community Suicide Prevention Match last year. So we started with an interest, and I think a collective interest, in looking, as Richard said, about what can happen within communities. And I liked what Richard said about when we talk about roles we play, and we all have a role to play, but what does that really mean, and how can we make that practical for people based on the evidence that is being gathered around the world, internationally as well as domestically? We were really interested in looking at multi-level approaches, as Richard said, more than one intervention in a community at the same time, and how those can work synergistically to have a greater impact. So not looking at one intervention, for example, of means reduction, but how does means reduction and promotion, crisis support, and recovery work together very practically? We also heard that for this to work, and you're building community programs, the community is involved and needs to lead these programs for their community, for it to be sustainable and to have an impact. How does the evidence base help communities. So with this in mind, we set out two objectives that you see here on the slide. The first is to look very practically at what the elements and aspects are of effective comprehensive community suicide prevention models and strategies. And then secondly, to identify the roles and responsibilities of the different players that would be involved. The match itself had a wide range of participants. We were 29, I think, all in all, and that's big for an IIMHL match, but I would propose not big enough to really capture, as I said, muster the evidence and the information and the best practices that are out there. And it's one of the reasons why we were collectively interested in continuing this discussion in this type of webinar series. We had participants really from around the IIMHL countries, which was great. We started our interaction actually in developing the agenda together and started sharing information amongst ourselves online in advance of the meeting so that we could have a really more of an in-depth conversation. As far as the information sharing at the match itself, what we were looking at doing is being very practical and looking at practical experience. To do that, we wanted to pick a couple of programs, models, or strategies that we could talk about together as far as what the lessons learned are, what the evidence is, what the evaluations look like, to start to make some connections around principles of what works and why. You'll have on your slide here the 6 models or strategies or programs that we looked at as part of our 2-day discussion. The criteria for choosing these models essentially were a number of things. First, we wanted to ensure that they were programs or models that were functioning at a multi-intervention level, that in a community, that they were community-based models. And a community for our purposes could be a geographic area, or it could be a setting or a population. And you can see from the different models and strategies we looked at, they are not all directly comparable. So we had some discussions around a population-level strategy in Quebec in Canada versus some school-based interventions in the United States. And an Aboriginal Suicide Critical Incident Response Team in Canada. But it was really to look at how these programs worked and why they worked, and really just to start a discussion. In 2 days, you can't get too deep into any one of them. And so we were sort of touching sort of broadly some of the large questions around them. We wanted also to hear from those who were involved either in the development of these models or strategies or in the delivery of them. And that, to some extent, was also an important factor in which ones we discussed quite practically who was available at the time to participate and share their experiences with us. So a last comment on this before I turn it over to Ed is just to stress again that our purpose in this discussion last year was not to compare these models or strategies. I think that would be a complicated process to do, but really to learn more about them from those that were directly involved in them. We wanted to work with those that had an evidence base behind them and had some evaluation, but we didn't dive too deeply into what that evidence base should be or would be, and I think that will be coming out more in future webinars and conversations. So with that, I'm going to turn over the rest of our presentation today to Ed Mantler to talk a little bit more about what we heard at the meeting and where we'd like to go from here. Over to you, Ed.
Great. Thank you very much, Stephanie. As both Stephanie and Richard had alluded to, as we heard about these 6 models of community suicide prevention, what we learned was that that a multifaceted approach that involves various aspects of the community is an important aspect. And in general, looking at the models that we reviewed, they typically tend to use interventions that fall within 5 areas within the community. They tend to include public awareness campaigns, brochures, posters, broad use of social media, and ways to generally raise awareness amongst the community of suicide prevention. Training, in particular training for physicians and for first responders on how to recognize suicidal activity and knowing what to do about it. So that specific training is important, but also training of gatekeepers, people in the community who may be able to recognize when someone needs help and need to know how to activate the system. That might include teachers. It may include social workers and healthcare workers. It may include members of the faith community and clergy. Specialized supports, such as crisis lines and other supports for high-risk groups identified within a specific community. And every community may have some difference in terms of what the high-risk groups are based on the demographics of that committee, but paying attention to those high-risk groups and providing supports is one of the keys to success. And of course, in any community, those who have already had experience with suicide through an attempt or as a survivor of suicide loss are a high-risk group of the highest, needing considerable attention. And if I've just lost my screen, so if someone could move the slides for me when I indicate, that would be helpful. The other couple of components that are necessary, ideas for means restriction. Now in Canada, means restriction typically means looking at the infrastructure around bridges or railway crossings. More broadly, it may mean looking at pieces of legislation or practices for dispensing of medications or for the use of firearms. And of course, any comprehensive model should include research and evaluation, evaluating the project, setting research priorities, and acquiring the data to monitor the impact as well as the effectiveness of the program. So on the next slide, what did we learn? Well, we came to agreement that a key objective of the match would be to identify those key ingredients or those aspects or elements of effective comprehensive suicide prevention community models. Following the presentation of the various community models or approaches, participants in the match were challenged to identify what are the key themes or underpinning approaches. A thorough analysis and discussion generated consensus on the following 13 elements, which you'll see on the screen, that should be incorporated into any effective approach to suicide prevention undertaken on the community level. It should be comprehensive, and you've already heard multiple interventions geared towards a wide range of individuals across a variety of settings. Should include measurement and evaluation, measuring the outcomes and evaluation of the interventions in order to determine the effectiveness of the program and inform future interventions. It should be designed in a way to allow for continuing funding and leadership of the initiatives after the program or project under study has been completed so that the intervention can be sustainable. Interventions should address suicide prevention across the entire spectrum, including prevention, intervention, and postvention services. Programs should be designed in a way that enhance collaboration amongst stakeholders and get the entire community involved. Every community is different, so interventions should be flexible in as much as they're tailored to the community in which they're being implemented. And they should involve and engage people with lived experience. Individuals bereaved by suicide, caregivers, these people have an important role to play in guiding community-based suicide prevention efforts. Initiatives should ideally be community-led and community-centered, tailored to the community's current level of readiness, and engage and empower local stakeholders to drive initiatives forward. Interventions need to be designed, implemented, and evaluated in a manner that is culturally responsive and appropriate for the community as overall, as well as for specific subpopulations. They should be recovery-oriented in order to focus on providing citizens with hope, treating them with dignity, and including them in meaningful ways in decision-making. In order to advance suicide prevention efforts globally, creative and innovative ideas need to be attempted, evaluated, and shared with other jurisdictions. These should be evidence-informed, selected for implementation due to the different kind of evidence that may be available to support those interventions, including evidence that's generated outside of traditional peer-reviewed qualitative studies. And last but not least, efforts should be strength-based. Focus on building on existing strengths within a community rather than strictly on trying to close the gaps. On the next slide, you'll see a depiction of our vision for action. It was generally agreed that comprehensive approaches must include both community interventions and health system interventions. And Richard had identified that issue, and Stephanie also spoke of a parallel match happening at IIMHL on the Zero Suicide Initiative. Participants could envision roles within the community for various stakeholders, public health officials, teachers and youth, existing suicide prevention groups in the community, peer groups, of course individuals with lived experience, law enforcement, mobile crisis teams, loss teams, criminal and juvenile justice systems, including judges, correctional officers, probation officers, prosecutors, spiritual leaders and faith community leaders, funeral home directors, crisis intervention teams, legislators and elected officials, pharmacists and pharmaceutical companies, and of course all kinds of stakeholders that are able to influence means restriction, which may be gun shops, gun clubs, bridge authorities, and local municipalities. When looking at target populations on the next page, I won't go through all of the target populations in detail, but I would like to focus your attention to the column on the right. When implementing comprehensive community approaches, there are various populations that could potentially be captured by targeting interventions at various settings. But importantly, there are populations that will likely be missed. It's important to review populations likely to be missed by interventions, which could include some high-risk groups, high-risk youth, dropouts, those involved in the criminal justice system, perhaps the elderly. Interventions can then be put in place to ensure that members of these groups, the hard-to-reach groups, are served in other ways. The next slide highlights the importance of measurement and evaluation when developing community intervention strategies. Several challenges regarding evaluation were raised, including the fact that there's often a lack of funding for evaluation and that there's often a lag in the time to publish the results of evaluations that have been done. There's also a tension between the need for real-time data and peer-reviewed research. Peer-reviewed research and the publication of it takes considerable time, sometimes years, whereas at the community level, real-time data is needed to know whether these interventions are working or where attention is needed. There's also tension between what's valued by researchers and communities. To be useful for communities, we need to make evaluations understandable so that communities can use it quickly for programming. Our group also identified several key factors that could facilitate measuring the success of community suicide prevention approaches: tracking fatal and non-fatal overdoses, suicide attempts, and suicide deaths, changes in behavior, knowledge, attitudes, and culture, upstream indicators such as school dropouts, intimate partner violence, and the number of gatekeepers trained and the number of referrals by gatekeepers, as well as tracking policy changes. It was reinforced again that we need to be vigilant about tracking and preventing suicide attempts because it helps people acquire capacity. There's also a recognition that there's a lag time in the availability of the data. On the next slide, regarding disruptors, the group discussed what disruptors are required in order for us to see more dramatic change with respect to community suicide prevention. In healthcare, the Zero Suicide Initiative has had great success creating an international declaration and a social movement for healthcare organizations to coalesce behind. While some of our participants were uncomfortable with taking a social movement approach, there was general agreement that we need to be much more assertive in getting engaged. More activism, more advocacy is needed. Given the number of deaths by suicide and the number of suicide attempts each year, it's surprising that we're not more vocal about how urgent this need is. To date, it's primarily been survivors of suicide loss that have been advocating for change. More can be done to activate community action on suicide prevention, not only driven by crisis. One solution might be a community activation plan, documenting various stakeholder groups, determining how to engage with them, and strategize about which messaging will resonate best. On the next slide, part of the vision of IIMHL is to accelerate change. And to accelerate change, our match promoted discussion and collaboration, and it accelerated change by emphasizing the importance of the perspective of individuals with lived experience across the continuum: suicide attempt survivors, survivors of suicide loss, caregivers, and their full and active engagement in community suicide prevention efforts. The group reinforced the importance of upstream investment in suicide prevention that strengthen protective factors and build community wellness and community resilience. Helped us to more overtly articulate the tension around suicide prevention that holds us back and detracts us from moving forward towards our goals. Some of the tensions include a focus on at-risk populations versus a broad upstream prevention initiative, medical models versus community development models, and initiatives that are community-built and led versus those that are prescriptive. The match sparked ideas on how to incorporate innovative, risk-taking, and disruptive change and help accelerate us forward. So on the next slide, what's next? The match will create a detailed report on the discussion for distribution to all participants, and this report is now available through the IIMHL website. SAMHSA has taken the lead on hosting this series of webinars, and future webinars will focus more specifically on some of the models that we looked at. We'd like to establish and grow a diverse international network of individuals, groups, and organizations interested in community suicide prevention. Our goal is to develop a blueprint for community action. The guiding principles of the systematic, comprehensive suicide prevention approach, as well as the underlying values that were developed by our match through consensus, will lead that blueprint as a foundation. It's precisely because taking action to prevent suicide is complex and difficult that we need a systematic and comprehensive approach to guide our efforts. On the next slide, you'll find contact information for both Stephanie and myself. And I believe Eileen will like to give you the opportunity for some questions.
I would add thanks to both you and Stephanie. That was an excellent presentation, and we have been getting some phenomenal questions. I want to let folks know in advance that we will send you a list of the questions in a week or so, along with answers, any that we don't get to today. So thank you for your continuing participation, and for just a reminder that in your upper left-hand column, you can type in Q&As. So we will have just 5 minutes for Q&A before Jerry Reed's presentation. And the first one I'm going to ask you is, what have been your salient takeaways from your efforts so far? And that's for Ed and Stephanie.
I think I'll maybe start that, Stephanie. I think the most salient takeaway for me has been the need for a whole of community comprehensive approach. Those models that have shown success that we reviewed at the match tended to all encompass at least 4 or 5 of those pillars that I showed on the intervention slide. So they tend to encompass training for gatekeepers, training for physicians, targets on targeted activities towards high-risk populations, broad community awareness raising campaigns using social media and other mechanisms, means restriction, and of course recognizing the need for proper research and evaluation.
I would further what Ed is saying and Stephanie here around that, and when you're bringing together comprehensive suicide prevention in communities, what the really exciting piece of this is that there's so much knowledge in the communities themselves, and then there's so much work and momentum and research within the academic communities and across other parts of policy development and government in different areas, that bringing all of this together with the communities so that we're all working from a systematic approach with the best available evidence that we have is really exciting. And my takeaway from our meeting last year was there was a tremendous momentum across many different countries and across a number of different programs and strategies to work together on this. So I think that is exciting. I also think it's exciting when you start to look at it from a broader perspective of, again, what we can do together. I think there's, I think the sky's the limit.
Thank you. We have time for one more question if you both speak quickly. And the question is, how do you evaluate success of those global suicide prevention initiatives? What has worked and what has not worked so far?
So Ed, why don't I start? Because I think the answer for me on that one is that that was one of the big questions that we had when we started our discussion in Vancouver, and we didn't really get to it fully. I think Ed had a slide and did a little bit of a presentation about what we heard, but quite honestly, we ran out of time. And how those elements are evaluated, I think, is a really good question as we go forward with this webinar series, that we can gather a little bit more information, discussion, and evidence around that. Ed, anything to add on that?
No, I would totally agree with that. I think that that we had considerable discussion around recognizing the fact that relying fully on peer-based, peer-reviewed research has its challenges in that the knowledge isn't exchanged quickly enough with communities to be able to know on an operational level the impact of the work that they're doing. But we've not come to as good an understanding as we would like to about what those process and outcome measures operationally need to be during the intervention phase.
And also bringing in some of those non-traditional learnings in communities and bringing that that experiential learning to bear on the evidence. I'd like to learn more about that.
Yeah, I think that's particularly relevant when we're talking with when we're talking with and about Indigenous populations. So, thank you both very much for an excellent presentation. And it's my pleasure to reintroduce Dr. Jerry Reed, who, among his many roles and titles, is the director for the Suicide Prevention Resource Center in the United States. And Jerry, before you do your formal talk, I'd like you to give us a quick explanation of zero suicide, and the reason I'm asking you to do that is that at least half the questions that we've gotten so far are actually mention zero suicide. So if you wouldn't mind doing that before you actually get into your prepared presentation, I would appreciate it. Thank you.
I would be happy to do that, Eileen. And to all of you, good morning, good afternoon, or good evening, wherever you are. I'm Jerry Reed. As Eileen said, I work for the EDC, the Education Development Center, where I have the pleasure of directing the SAMHSA-funded Suicide Prevention Resource Center, among other things, and also serving as the lead for what we call the Action Alliance for Suicide Prevention, but we really run here specifically the Secretariat of the Alliance, so we try very hard to look at the big picture, and it's in that context that I'll talk to you. Part of that, to Eileen's direct question, is where we are with zero suicide and, frankly, how we got here. As both Stephanie said and Ed and Richard, there's several really key points that that I think really warrant a bit of a repeat. Richard said in his introduction, that member nations of the WHO are encouraged to reduce suicide by 10% by 2020. And there are quantifiable, measurable goals at the world level, but each of us, probably across the world, have our own respective quantifiable goals, or if we don't, we probably someday will. So we have to think very concretely about how we can reduce suicide. And another reality that I think we've all experienced over time is suicide prevention was largely seen as a mental health challenge for our field. And over time, and I think evidence of both Stephanie and Ed on the presentation from Canada indicate that it's both a mental health and a public health challenge. So we have to look at interventions or approaches that allow us to really look at suicide comprehensively from both a health and a non-health perspective, to include, public health specifically. So zero suicide really evolved trying to reduce the number of lives lost and injuries incurred in healthcare and behavioral healthcare settings. That was its focus population. And it's not enough to just, have a door people can walk through and present with suicidal ideation or suicidal thought or suicidal behavior if what they're getting once they walk through that door isn't comprehensive in terms of treating the total patient from entry to exit and far beyond once they're back in the community. So one of our healthcare systems here in the United States, the Henry Ford Health System, really looked at that. They looked from the perspective of depression care and offering perfect depression care. And in the context of that delivery, someone said, well, if we really delivered perfect depression care, we'd have zero suicide. And so that, in a way, was the birth of zero suicide, and it really had to do with looking at transforming the delivery of care more than just the heroic effort, to use one of the terms Dr. McKeon has put forward, the heroic efforts of a clinician and a patient, because it's far, far more than that. So what zero suicide is very similar in many ways to what Stephanie presented and Ed on the programs they looked at when they thought about community suicide prevention. They were multi-level interventions, not just one and finished, but really looked at comprehensive delivery at the community level, something like the Air Force suicide prevention program that had 11 different interventions that they were applying in the Air Force community, which ultimately led to a 33% reduction in airmen suicide, but also had other benefits such as reductions in domestic and severe family violence or driving under the influence of alcohol. So we learned through some of those interventions that have been looked at that it's more than just one thing that you do in a setting that's going to contribute to reduction of lives lost or injuries incurred. So when it comes to zero suicide, that is for health and behavioral health, and it really means things like assess every patient, treat suicidality, not just the is competently and compassionately trained to intervene with patients who present for suicide. Make sure that best practices are applied to patients at risk. Make sure that we measure our success with these patients, and just as importantly, make sure we continue to follow up with these patients long after they leave our facility, and in short, assume responsibility as a healthcare system for their recovery and their return to wellness, and not just treat it as an acute presentation that is dealt with. So I wanted to kind of just bring you up to speed to get to Eileen's question, and I now will kind of tell you how that really led us to what I'm going to talk to you about today. Since we had such a system in the United States that was directed by our Action Alliance, which is on the slide before us, and for those of you who don't have an Action Alliance, this is the public-private partnership that was formed as a result of our national strategy, which includes private sector partners and public sector partners. and we want to bring everybody that has a role in either government or the private sector to help us reduce suicide to the table to inform our direction. So this has been in existence now for 6 years. We have both a private sector lead from Union Pacific Railroad and a public sector lead from our Veterans Administration, and we have honed in on 3 priorities from our national strategy that we really think have the greatest potential to save lives. One of those is changing the conversation. One of those is transforming health systems, and that's the Zero Suicide program I just spoke to you about. And one of them is transforming communities. Because putting it quite simply, if in this country we lose 43,000 people a year to suicide, and we know that less than 50% of them touch a healthcare system, where do we find the other 50%, which is really the point that I think Stephanie and Ed were making earlier. We're going to find them in our communities, and we're going to find them sometimes in community agencies, but sometimes we're going to find them in homeless settings or in court systems or in places that we're not accustomed to looking for people who may be at risk for suicide. So the Action Alliance really, in their last meeting in March, now that we have a very robust and vibrant approach to zero suicide going on in this country, they directed our committee to look at transforming communities by helping communities with the same kind of guidance on what to do and how to do it to save lives in the community. So having said that, they've organized themselves by a number of task forces, and this was one of the tasks they gave us in March of last year that we've been working on. So I, along with my 2 colleagues, Mr. Robert Gebbia, who's the CEO of the American Foundation for Suicide Prevention, and Dr. Jim Mercy, who works for our Center for Disease Control and Prevention, have joined me, and for the last period of time, several months, we've been chairing a committee to try to figure out how do we help communities really learn to organize around reducing suicide in their communities. And it's a very different challenge in many ways than it is in the zero suicide world, because in zero suicide you have a boundaried community. You know how many people come to your healthcare system. You know how many people come to your behavioral health system, and you can see how many of those, if you get better and deeper into surveillance, you can figure out how many people may have died as a result of having touched that system or after touching that system. So you can engage in continuous quality improvement by monitoring that metric and trying to get better and better and better and eventually working towards zero suicide. Whereas in communities, that's not quite the case because it's a denominator that's constantly changing. So we had to think about what it would be to really try to figure that out. So our mission was to identify, much like Stephanie and Ed did at the IIMHL meeting, a core of set elements and a strategic framework to try to figure out how we could give guidance to communities to move this mission forward. And our commitment was to develop a white paper that would review the available literature, explore existing resources, and there are so many out there, as Dr. McKeon stated, and Stephanie and Ed, that are certainly well known to all of us, but we were wondering what might be the common elements in each of them that seem to speak or seem to repeat often. And really you could see the relevance of that particular element in terms of helping a community really, really try to make a difference in the community that they were trying to affect. We've seen in our history, as brief as it may be in the suicide prevention field, we all want to do something good. We all want to do something positive, but what we've done often isn't informed by data. So I would clearly say to you that one of the most informative pieces that we've taken from this is start with the data in your community, because it may be very different in one community versus another. But just to give you an example of how we got started, as you can see on this chart, we looked at evidence-based programs that were out there and that seemed to be making a real difference in reducing lives lost and injuries incurred. We looked at programs that were models being proposed at the community level here in the U.S. or down in Australia, and we certainly looked at the effective suicide prevention model that SPRC puts out in terms of how to work in a community to make a difference. And we looked at other projects and programs that were out there that weren't specific to suicide, but they certainly seemed to suggest they had an effect on community change. And we wanted to look at those and include them in our eventual report. So our timing for this project is to complete the paper this winter. We just met last week with a group of about 20 folks representing communities and researchers and developers and government officials, et cetera, as well as parts of group members of my team to see where we were with the project and how it was evolving. And we also are determining the next steps for presenting this model to the Action Alliance itself, the executive committee, so that much like we did with Zero Suicide, the vision came from the Action Alliance, and eventually we've created the Zero Suicide website, and we're now training communities and hospitals in particular, let me be clear, training hospitals and behavioral health settings how to implement Zero Suicide. Our hope is that once we nail this down and really have consensus that we've really hit it, we plan to do something very similar, a website to give people background on how to do some of these steps. And certainly we would love to, help communities engage in this work so they can reduce the burden that's present in their community. What I can tell you that inspired this work is while there's a lot of wonderful work going on, what we have learned is that there's no community that has yet successfully reduced the challenge of suicide in their community across the board. They've had pockets of success, but comprehensive integrated success still eludes us. And I don't see that as a bad thing. I see that as really an evolutionary thing. That's probably exactly where we should be at this point in time. We started with Zero Suicide. Now we're starting with communities, and I hope at the end of this journey, when we get there, we're going to be able to see reductions in healthcare settings because we're implementing the best healthcare humanly possible with patient safety as our guide. And similarly, we're going to be doing something very much like that in the community. And as we wrote our national strategy, as I believe Dr. McKeon mentioned earlier, we did so with the first two strategic directions being all about creating prevention-prepared communities. Treatment was strategic direction 3, which is the Zero Suicide piece, but that prevention-prepared community readiness is strategic direction 1 and 2 that we're putting a full court press on right now as part of our efforts in the community. So I will stop at this point so I don't exceed my time. I know we have questions for everybody, but I'm very encouraged, and what I hope we eventually see is that a community will look at the data in their community in terms of what populations are dying, what populations are at risk, and what evidence-based practices do we have in our field, and what leadership do you have in your community and readiness do you have in your community so that with the guide that we ultimately hope to prepare, and I can tell you that the elements that we're looking at are not too far off from what Ed and Stephanie were looking at right now preliminarily, and I will say it's just preliminary. We're looking at elements like how do you obtain broad-based support and actually build it? How do you create a clear and united vision? How do you unite people? And people not just in our sector, but outside our sector who'd have a legitimate role in helping us advance this plan. How do you use a strategic planning process where you start with data, you assess your readiness and your resource availability, and you go where burden exists and then monitor those reductions that you hope will happen as a result of your strategic effort. You integrate what you're doing in the community with what's happening in the healthcare side so that when we identify people at risk in the community, we're sending them to suicide safer care that's going to make sure they get well and stay well once they walk outside the door of that health facility and stay connected to the community when they re-enter the community with competent, caring clinical services. We want to make sure we we allow for the tailoring of implementation. Every community is different, and we can't prescribe a one-size-fits-all. We certainly want to be encouraging people to communicate their victories and their successes, and if something isn't working, not be afraid to change. And lastly, we want continuous quality improvement to always be the overlying emphasis of what we're encouraging people to do. So we know whether or not we're moving in the right direction, and if we're not, we've got to step back, look at why, and then re-engage and readjust so we can hopefully reduce the burden that exists in our community. So with that, I will stop and turn it back to our moderator for today, Eileen Zeller.
Thank you, Jerry. When you look at where we were 10 years ago and compare that to what today's speakers have already described, it's pretty phenomenal. And I'm glad to be a part of the suicide prevention field right now. It's very, very exciting. And so, Jerry, you ready for some questions?
I'll try my best.
Number one. Yeah, number one. Have any community suicide prevention approaches been successfully implemented?
At this point, we, as I said, I think in my presentation, we certainly have pockets of excellence. We have states and communities that have done a very good job. Richard mentioned, for example, the Garrett Lee Smith communities that have, those that implemented a Garrett Lee Smith grant as compared to communities that had not implemented a Garrett Lee Smith grant saw reductions in both death and attempts for at least the first year. So there has been promising, views of how lives can be saved, but I think the point that everyone has made about sustainability is one that we have to, I'm going to get a little policy wonky here, and that is we can't live in our field from grant to grant to grant. We have to learn to embed these changes into the infrastructure of our community so they sustain long after a grant goes away. So I think that has to be a part of the community thinking. But in general, we have not seen communities tremendously reduce suicide by virtue of what we've done to date. But I think in all fairness to our community, the evidence base in our community, while it's growing day by day, is still not a tremendously large evidence base. So we have to keep evaluating and keep adding to that. And I think the other thing that we've not done that we're starting to see in the literature more and more convincingly is it's not a one-and-done response. You can't just do a gatekeeper training program and expect burden to decline. You can't just do a program in a setting and expect burden to go down. It may go down in that setting, but it's not going down in the community at large. It's got to be something big enough and comprehensive enough that it would move the numbers in the desired direction. So bundling best practices or bundling practices in a way that really kind of supports the strategic planning approach is the way of the future, and I think we all have to just get better at understanding that.
Thank you very much. And we have time for one more question before we turn to questions for all four speakers. And let's go with this one. How can you evaluate impact across jurisdictions when tailored approaches are taken in each community? And that's for Jerry.
Well, I think that one of the things that I'm probably most encouraged by from zero suicide is something I never really thought of in the first, 15 years of my career, and that is if you're looking at a healthcare system that is, made up of members that you can identify, the number of people in your system that you're caring for, and if you monitor and you intervene with a comprehensive approach and you monitor the results of that, how many people died in that system, and you monitor that year to year, and as a result of your efforts to continuously quality improve, you see those results decline and decline and decline because the system is more suicide safe and the clinicians are more properly trained, and the continuity of care is clearly documented and and really quite able to be communicated, then that's how you measure impact. If you look at a juvenile justice facility similarly, and you know how many young people are in that system or in the child welfare system or in the foster care system, we know who those kids are and we know who those youth are. And if we're losing them to suicide either while they're in their facility or shortly they're out of the facility, then we have to get better at knowing who they are and knowing what happened to them so we can make sure that the systems that are caring for our youth in child welfare or youth or justice are getting optimal suicide care in those settings. And I just think we just have to drill down to the point where we stop staying at the 43,000 level like in the U.S. when we look at our number of deaths and really try to better understand that, 23,000 of those deaths are people in the middle years of life, or 4,000 of those deaths are in youth, or 8,000 maybe in older adults, and really drill down to the point where we can find a system, identify the number of people in it, perform the intervention, and ultimately show the results of our work. That's the way we're going to reduce the suicide in member nations by 10% by 2020, only if we get to that level of surveillance and assessment.
Thank you, Jerry.
You're
And
welcome.
I want to read a comment from one of our participants that's relevant to the evaluation information that's been presented to this point. Community-based participatory research can invite community members to co-author peer-reviewed manuscripts. That way, community members can be informed of evaluation results in a timely manner, even though publication itself can take a while. I think that's a lesson
Right.
that we should all remember. And I'm going to open up the questions now to all four of our speakers, and I'm going to start off with how does the community approach link to zero suicide efforts in healthcare? And
Eileen,
any of
could
our
you
participants can take that. Yes.
could you say that again, because they announced that the mute button was going off just as you were posing the question.
Aha. Okay. How does the community approach to suicide prevention link to zero suicide efforts in healthcare?
Well, I would say that I think that they complement each other very well and need to link to each other, because we know, looking at the United States data, we know that many of the people who die by suicide are not in healthcare, and they're particularly not in behavioral health care. So identifying those who are at risk, encouraging them to get help in a variety of different settings, I think becomes a critical piece. And ideally, I think we would get to a point where we had a comprehensive suicide prevention model in which something like the Zero Suicide Initiative is going on in healthcare systems, and it is matched with a similarly detailed community effort, and where there are links and ongoing interchanges between them. Perhaps using something like a public-private partnership, which we think is really important because no one sector can do it alone. Let me speak to one issue which I saw came up in one of the questions, which has to do with the complexity of suicide prevention. And part of the reason that I think we have not seen more comprehensive approaches is that they're difficult, and even conceptualizing them needs some careful analysis. So, for example, on the one hand, we have to think about community suicide prevention across a range of settings, right? A lot of work being done in schools, and there's a lot of evidence around school-based suicide prevention that can be cited. A number of randomized controlled trials either that have been done or underway. So you've got educational settings where a lot of work is being done. There's workplace settings, faith settings, justice settings. So One way to look at this is across a variety of different settings where people at risk may be coming into contact. But that's only one way of slicing this. Another way of slicing this is the developmental trajectories towards suicide risk that people experience. And there, being aware that a comprehensive suicide prevention approach has to begin very early on with things like the good behavior game, which does have evidence, which starts as early as first and second grade, all the way to the people in the middle of acute suicidal crises. So there are a number of different ways in which we need to be able to better specify this so that when people ask, well, we're working so hard on suicide prevention, there's a lot going on, why, at least in the United States, why are the rates not going down, that we can kind of point to the complexity of what needs to be done and measure our own efforts based on how close we are coming to the work that we know does need to be done.
Thank you, Richard. I'm going to address this question, I believe, to Stephanie. I believe you're this one comes from Canada, and I believe that you are the person to respond to it. What can the public health units do within the scope of the public health standards to advance comprehensive community suicide prevention?
That's an excellent question. And it's a follow-on to a little bit about what Richard was talking about in communities. Once you're out of the hospital setting, where are the contacts with people, whether they be in schools or in the justice system, and what is the role of the public health sector or public health units? And I think that is worth really exploring that piece as an individual sector too, and how that connects in. And there may be some differences between sort of what level of public health that you may be working in. But certainly from at a federal perspective here at the Public Health Agency, it's really come to ground here over the last, I would say, 5 to 10 years around looking at suicide as a public health issue. So looking at all of the environment and determinants around suicide as part of that complex interplay, if you will, when designing interventions and programs, and how we get that into public health units as well, with whether it be safe messaging, proper interactions. When I say proper, safe messaging, suicide-safe interactions that the units may be having with clients or with the public at large. So the short end of that is, yes, there's definitely a role. Suicide is a public health issue and needs to be looked at it as such. And there are learnings, I think, that we could start to look at from other public health issues that we may be able to take and bring to bear on suicide prevention, and how we can have an impact on, one, reducing rates of suicide, as we've talked about, but also making our populations, or helping our populations, to be healthier and taking care of their mental wellness, and looking at ways in which we can augment the positive mental health that we have in our communities. And that's something I think that public health is well placed to participate in.
Thank you, Stephanie. Ed, I'm going to direct this one at you. Hope this one doesn't put you on the spot. Do you think it's possible to implement a zero suicide-based approach in communities?
That's an excellent question. I know that our colleagues from the Zero Suicide Match are working diligently at zero suicide initiatives within the healthcare environment, and we absolutely must work in parallel with that initiative. For us to have safer, healthier communities, we also need to have a safer, healthier healthcare system to respond when suicidal issues arise within the community. Can we get to a point of zero suicide in a community? I think that's an awesome aspirational goal that we should all be working towards.
Thank you. Does anyone want to add to that one?
Eileen, this is Jerry. I would certainly offer that, zero suicide, and it's really important that we say this, has always been an aspirational goal, and we know we have a long way to go to reach zero, if we ever reach zero, but I don't think that's the important question. The important question is, it has been so embraced by the field as a momentum and a goal and something people can shoot for, and it's been inspiring. So I would say that in a boundaried system where you know the number of members in a given community, and you can track the number of deaths or revisits or whatever in a system, then that's a measurement. That's a metric that you can get to. In a community, it's probably a lot harder to do, and in fairness, it wasn't designed as a community initiative. It was designed as a health and behavioral health initiative. So if we go there, I think it's fair to say, let's make sure that once the elements are created, similar to what Ed and Stephanie have done in Canada and what we're certainly doing now under the auspices of the action lines, let's get them developed first and make sure we create a framework or a model that's community relevant before we attach the label zero suicide to it. And we've kind of landed more on the side of, let's just create, for the moment, prevention prepared communities or suicide safer communities, so we don't mix the goals, because the elements for zero suicide are very different than the elements will be for community-based suicide or zero suicide if we go that way. So I enter that caution just for a moment. While I agree with that 100%, it's absolutely what we would love to get to. I think we need to be respectful of science and frameworks before we get that far along.
Yeah, thank you both. Excellent responses to that. Richard, this one's for you. Is there evidence to support gatekeeper training such as ASSIST and Safe Talk? Is there evidence to support their effectiveness in the literature or in communities?
Yeah, I'm happy to respond to that. So there are a couple of things that I would mention. And I think the way I would summarize it is that I think that there is good evidence that supports the use of gatekeeper training as one element of a comprehensive approach. We've referenced the European Alliance Against Depression. Community gatekeeper training was one of the 4 levels of that, and that did find some evidence, not perfect evidence, but it was evidence of reduced suicide in Nuremberg and in a couple of the countries that implemented it. So not perfect evidence, like our Garrett Lee Smith evidence, which was very heartening, that we were reducing suicide deaths and attempts in the first year, but then it faded. Now, in our efforts, I would characterize the activities that our grantees undertook as being kind of gatekeeper training plus. Everybody did gatekeeper training. QPR most frequently, but a significant number also did ASSIST and Safe Talk, and others used some customized gatekeeper training models, some for particular settings like youth justice settings, such as which was developed in the state of Tennessee. So no one was using gatekeeper training alone. They were all doing other kinds of activities, but there was also great diversity. So, and I think that gatekeeper training as a standalone intervention has the vulnerability that if it's not sustained over time, the training effects will fade. You can't do a community gatekeeper training in maybe 3 or 4 different places in a community in 1 year and expect that, 2, 3, 5 years down the line, it's still going to be having an impact. So again, to summarize, I would say, and actually I think this was also the overview of effective suicide prevention that John Manninol did about 10 years ago, I believe, came to a similar conclusion, if I recall correctly. The idea that there's evidence for gatekeeper training, but not as a standalone, but as one element of a comprehensive approach to community-based suicide prevention it has an important role. We also did some work studying the use of ASSIST as training for crisis hotline workers, and where that was found to be effective, and that research is also published.
Thank you very much. And that brings us to the end of this phenomenal, if you don't mind my saying that, website. What a wealth of information. I feel like I believe the field is on the precipice of a new world. I think the numbers are going to start to come down, and we're all going to be here to help make that happen. I'm very glad that this is only the first of a 6-part webinar series. Richard already told you what they would be. The dates and times are on your screen. I do want to remind folks that this webinar is being archived, and that the slides will also be available. We will send you that and follow-up information on this webinar series, on this webinar. I want to thank our wonderful presenters for the terrific job they did today in giving us an overview of advancing community suicide prevention. I want to thank all of the participants who stayed with us today. I hope that you learned as much as I do, and we will be back in touch soon. Everyone stay safe and keep doing the work that you're doing.